Next, we'll talk about body planes. A mid-sagittal plane is if the body was divided equally into right and left halves. When I hear mid, I remember straight down the middle. A sagittal plane, however, creates right and left planes that are not equal. The key component here is that they are simply parallel to the mid-sagittal plane. My personal mnemonic device for sagittal planes is the sagittal cut creates sides. A frontal or coronal plane creates a ventral and dorsal section. So if the body was cut in a way that the ventral cavity was separated from the dorsal cavity, and an example of this is the coronal incision. This is a cranial incision made from ear to ear, up and over the head like a headband. This separates the cranium into ventral and dorsal sections. Finally, the transverse or horizontal plane is if the body was cut in such a way that there was a superior portion and an inferior portion. When a magician cuts his assistant in half, he's creating a transverse section. Every single one of these body planes is relatable to a surgical incision. We are going to learn more about them in each specific specialty, but understanding the planes created will help you understand why the incision is made in the first place. Internally, the body is divided into large spaces. We call these spaces cavities, and within the cavities live our organs. There are two main cavities in the body, and they are the ventral and dorsal cavity. Because you already know what ventral and dorsal mean, you should be able to tell me where I would find the ventral cavity versus the dorsal cavity, right? The dorsal cavity is toward the top and back and contains the brain and spinal cord. It's relatively small when compared to the ventral cavity. The ventral cavity is toward the middle and front. It is comprised of two sections which are divided by the diaphragm. The diaphragm is inferior to the thoracic cavity, which is home to the heart, lungs, and major vessels, and it is also superior to the abdominopelvic cavity and contains the stomach, most of the intestines, liver, spleen, bladder, and uterus. There is an imaginary line in the abdominopelvic cavity that divides it into the abdominal cavity and the pelvic cavity, but they're not really divided from one another like the thoracic cavity is divided from the abdominopelvic cavity by the diaphragm. When we go to lab this week, you will see Sally Sindaver's abdominopelvic cavity and be able to conceptualize that it's all one big happy cavity. But if we're being specific, the rectum, uterus, and bladder are technically in the pelvic cavity. The abdominal pelvic cavity is divided into 4 quadrants, making equal transverse and mid-sagittal planes. Each quadrant can be described using its acronym, but make sure you don't get your R's and L's and U's mixed up, because that will be incorrect. This is important to the ST because every structure in the abdomen lives in a specific place, and if we're doing surgery on a specific structure, we have to know where it is to anticipate our surgeon's needs. So I'm going to rattle off the different structures in each quadrant, and you're probably going to have to pause and rewind me a few times to get it all. Do it. In the right upper quadrant lives the gallbladder, liver, a portion of the transverse and ascending colon, the hepatic flexure of the colon, the distal stomach, and a portion of the small intestines. In the right lower quadrant lives the appendix, cecum, a portion of the ascending colon, a portion of the small intestines, the right ovary, and a portion of the uterus in females, the right ureter, and a portion of the urinary bladder. In the left upper quadrant is the pancreas, the spleen, the proximal stomach, portions of the transverse and descending colon, the splenic flexure of the colon, and a portion of the small intestines. And finally, in the left lower quadrant is a portion of the descending colon, the sigmoid colon, the left ovary, and a portion of the uterus in females, the left ureter, and a portion of the urinary bladder. I know, you're probably getting tired of all this, but we're not done yet. We've got quadrants, but that's not even good enough. So we have abdominal regions too. Ultimately, the quadrants are used more frequently than the regions are, but the quadrants are helpful when discussing the different organs. The regions, on the other hand, are paramount in describing precisely where an abdominal hernia can be found. When we talk about hernias in general surgery, you'll realize the regions are helpful to you because hernias can be small and anywhere from the diaphragm to the pelvis. On your slide, you'll see there are 9 regions. If you think about a tic-tac-toe board, let's find these regions and work from the middle square outward. The middlemost square is the umbilical region. This is where the belly button is. Above that is the epigastric region. Below the umbilical region is the hypogastric region. To the right of the umbilical region is the right lumbar region, and opposite that is the left lumbar region. Up and to the right is the right hypochondriac region. In this region, medical terminology is helpful because the word hypochondriac literally means below the cartilage, which in this instance means directly below the ribs. Up and to the left of the umbilical region is the left hypochondriac region. Down and to the right of the umbilical region is the right iliac region, which coincides with the ilium of the pelvis. And the last region is the left iliac region. And just so we're clear, no one ever calls the regions by their acronyms. They always say the whole thing, which is unlike the quadrants, where they almost always do use the acronyms. I tell you this because I don't want you walking around saying there's an inguinal hernia in the LIR because no one will know what you're talking about. Okay? Now we're going to cover some abdominal points of reference that are crucial for the surgical team to know because they are anatomical landmarks in the surgeries dealing with that specific anatomy. These are not in any particular order, but I've highlighted 6 landmarks because when you head out to clinical in a few short months, chances are you're going to get started in abdominal surgery, and you're going to hear these terms regularly. So grab your pens and write this down. The triangle of Callot. Say Callot. The triangle of Callot is a space created by the anatomical landmarks near the gallbladder. That means it's not a thing. It's a space created by other anatomical structures coming together. Okay? The anatomical structures that come together to make the triangle of Callot are the cystic duct, the common hepatic duct, and the inferior border of the liver. Shown here, the cystic duct is green, the common hepatic duct is green, and the inferior portion of the liver is red. Inside this triangle is the hepatic artery. If we go in there and we injure the hepatic artery, the patient is in grave danger. So, the surgeon is going to identify this invisible triangle in the middle of the surgery prior to dissecting any tissue. Depending on who you get to scrub with in clinical, this tiny triangle comes up as a quiz item all the time. Next is Hasselbalch's triangle. We will cover this big time in general surgery, but it's another potential space in the human body that allows us to use anatomical landmarks to repair inguinal hernias. Its 3 sides are made up of the rectus abdominis muscle, the inguinal ligament, and inferior epigastric vessels. The trigone of the bladder is another quote-unquote potential space triangle located inside the bladder itself. We're going to cover it again in the genitourinary unit, but it is formed by the two openings of the ureters and the urethral opening. Again, this is inside the bladder. So the only way you can see the trigone of the bladder is if you are inside the bladder. We're going to talk about how we get there next week during minimally invasive surgery. The ligament of Treitz marks the end of the duodenum and the beginning of the jejunum. We will talk extensively about the intestines during our general surgery unit, but this point of reference is so important in bowel surgery because it helps us know which portion of the bowel is diseased or injured. The hepatic and splenic flexures are specific to the organs they take their names from. So, the hepatic flexure is near the liver, and the splenic flexure is near the spleen. These flexures are where the large intestine turn inside the abdomen. Without them, the large intestine would be all flippy-floppy inside our abdomen. These flexures are very important in large intestine surgery.